Hi, I'm Lawrence Redsky from Jewish General Hospital in McGill University in Montreal, and I'm here together with Rafael Vidal Perez. Rafael?
Hello. Hi. For me, it's a pleasure. I want to thank, first of all, JACC case reports and the ACC Imaging Council to organize this nice session. We are going to discuss one great case that is going to be published in JACC case report. And it's for me a great honor to host this webinar together with Dr. Lawrence Rusik and the Council of the ACC Imaging. This topic that is about how to close mitral paravalvular leaks with a novel twist, that is the use of 3D printing to help plan and guide. We have a case from Dr. Marco Alcántara from Mexico City that is going to be published in JACC case reports, and now we have with us an expert international panel that encompasses all the career stages and Spanish across the Atlantic, so it's a global session. We have Dr. Nadir Hamid from Columbia in New York City. He will be speaking about echo to guide the paravalvular leak closures. Dr. Joe Martucci from the McGill University Health Center will be describing tips for closure from the perspective of interventional structuralists. We have Dr. Israel Valverde, who split his time between Evelina London Children's Hospital and the King College of London, and also the Hospital Virgen del Rocío in Seville. And he will give us a primer on 3D printing, and finally we will end with Dr. Pascal Terial-Lanson, who is a cardiology trainee at the University of Ottawa Heart Institute, but he's also an expert at developing modeling software for structural heart disease. And we will ask an introduction how to use software to design these 3D solutions. After that, we will make a panel discussion. I will start with the presentation of the case. And I will urge you to enter questions in the chat box, and we will get to many of these questions and have them addressed by our expert panel. So to not lose more time, I will share you this interesting case, and we will see how it looks like, and then we will have an interesting discussion on all these aspects that are really of interest. I think you see my screen now, so I will show you the case from Marco Alcántara. This is a hard team case at the end because we have to take decision on how to deal with this. And it's a case coming from Mexico City. It's a 70-year-old woman. The past medical history of the patient was rheumatic valve disease, polymyositis, renal disease with glomerular filtration rate low, 27 millimeters per minute square meters, and COPD in Gold 2 stage and rheumatoid arthritis. Valve surgery was performed in 2014 with two valves, mitral carbomedics 29 millimeters and aortic carbomedica 25 millimeters, and he has an history of heart failure in two episodes in the last month. You can see here in the transfer imaging the important insufficiency due to a paravalvular leak, and this is the point that we are going to treat in all this session. The heart team decision was needed in this case because of the evolution of these heart failure episodes, and they decided to go for a percutaneous leak closure. And did need some previous study. It's important. One point is using the 3D echo that give us a lot of information. You have the vena contractor 2D, vena contractor in 3D with different diameters, and you know that the techniques sometimes there are not the same measurements, and this is a problem. So many times you have to go for different techniques because it's very important to decide what is the right size of the device. Here they have one proposal that was one of the devices that we show here in the presentation that has some measures that are the ones that we show in the slide. And another part of this study that is very important in the leak measurement was the use of CT scan. That is one of the elements that will help us later on to do the 3D printing. So we have this area of 2 square centimeters. The point is that we can expect some oversize with the device. Maybe it's 20-30% oversize in this case. We have these diameters that are, as you see, not the same of the device. So one idea that could help us, and this is one of the main points of interest of the case, is simulate what we are going to do. So they get a 3D model, printing the CT scan of the patient, showing where is the leak, and think how to close that. And this is the size that is not so regular as you see. Then you can think different devices that we have in the market to try what could enter here. That's one point, maybe a bigger one. It depends. So you have also to take into account if you can have interference with the valves. So you have to take the right size of device. And also it's important the relations of the leak with the aorta and the left atrial appendage. So one strategy, as you see, we have the model, we can see what is going to happen with this device that we are going to use. We could think exactly where is the right place to deliver the device. And as you see, you can see how they are trying in the 3D model, if it's attached correctly or not, and if it will detach in a correct way or not. So, and then you will see also how it's during the procedure. It's very important to monitor, and here is how it was the leak and the insufficiency that we have in this case. Of course, another important point on this case was also the use of the Echo Navigator that is integrating the fluoroscopic imaging with the CT data, and also we can integrate sometimes also in the imaging of the 3D transesophageal echo. One important point of which is the transeptal puncture, here an essential role for the transesophageal guidance to the people working in the lab to the structuralist, and they need to get this orientation. It's important always to remember where to puncture and thinking where we go. Sometimes we can puncture in the same place that in other procedures. It depends where we want to go after with the catheter. Of course, multimodal imaging could show us what is going on, and if we need some other elements to help. In this case, the Mullin sheet couldn't cross the fossa ovale, well, the interatrial septum, so they need the help of a balloon septoplasty to get the access for the sheet. Here you can see that they're using a different sheet to get to the right points, and because here is very important in the management, the different catheters, and to get there in the right place to go with the guide where you can see here all the maneuvers to get over the place of interest. Of course, another element that is essential is the guidance by the 3D echo to know where the guide is going, and if we are going to be in the place that we wanted to be with the 3D model. Now we know where we wanted to put the occluder, so we have more or less orientation to that. And here you see how it's placed, and you need this support guide wire in the left ventricle to do it correctly. This is one of the points. We will discuss it probably on the management with the interventionalist in the next step of our session. Of course, we will see how the deploy of the device is performed. You can see in the left how it's deployed the device in the left, and then how it's very important also to have into account the marks of the device, because it's the way that we orientate in the fluoroscopy. Of course, we have the image of the 3D, but I think it's the combination of both where the imaging specialist and the interventionalist get together with these two images at the same time. So you need guidance in the two areas, in fluoroscopy and imaging. And here you see how the device is released, and we see that there are no interference with the valve. That is one of the essential points that we could expect as we plan it with the 3D printing. Another point is this absence of no screw system that give us more release predictability. That is also important. You see here the final result of the case. But you see that here we play a lot of imaging techniques that now is the way to do things. You need multimodality, and it's something that we need always. I think we have in this moment we get Marco here. I don't know if he could give us some additional explanations on the case, because I see that he appeared in the chat. So I will stop to share my screen, and we will come with the next presentation, maybe with some comments of the author of the case.
Yeah, Marco, it's too bad. I feel badly that you had difficulty with internet connection, but we'd really like if you can summarize just a few of the key points for the case presentation, and we have a question for you afterwards. So if you can just tell us what made this case unique and how the 3D printing helped you.
Can you hear me, Lawrence?
We can hear you, but now you are muted. I think you have some echoes.
I believe when you have a very difficult case, if you have more information about the anatomy of the patient, then it's worth, because you can plan in advance what you're going to deal with. In this case, Rafa already said that it was very important not to interfere with the previous prosthetic valve in the mitral position. So when we start playing with a 3D modeling design, then we were quite confident that when we were performing the real case, we won't be having that trouble. So I believe as long as you can have more integrated information on the anatomy of the patient, it is very valuable so you can do complex cases. Thank you very much.
Thanks. We'll have you back a little bit afterwards. Now we're going to have Dr. Hamid tell us about echo guidance for paravalvular closure.
Okay, can you hear me all right here?
Felipe.
Perfect. Thank you so much. Good morning, good afternoon, good evening to everyone, wherever you are in the world. Thank you, Dr. Rutsky, Dr. Vidal Perez, and JACC's report for the invitation. It's my honor to be among the esteemed faculty. I have no financial disclosures, and today I'll be talking to you about the echo imaging with regards to mitral paravalvular leak closure. And the echo imaging success takes you back not only from pre-procedural, intra-procedural, and post-procedural assessment. And so transthoracic, we know, is limited due to the acoustic shadowing from your prosthetic valve, and TEE and 3D echo, as you've seen in the case, is really superior in terms of assessing for paravalvular leak. And so for pre-procedural imaging for paravalvular leak closure, really the key is to locate and to find the number of defects. You want to identify the shape, the exact size of each of these defects, the distance, and the orientation of the defect to the sewing ring or the prosthesis. So really, first step is the 2D and color Doppler of TEE to really localize the defect. So here in this case example, you can see really my advice is really meticulous advancement of your probe forward every 10 to 20 degrees. And you can see in the top left-hand side at 0 degrees, really severe paravalvular leak in the lateral aspect of the bioprosthetic ring. And here you can see on the right-hand side that really there's partial dehiscence of the bioprosthetic ring. And what's really significant, as you can see in the arrow on the bottom left-hand side, you can see an echodense mass, which presumably it could be a torn suture, and other differentials include a vegetation, but certainly the infectious workup, all the cultures are negative in this patient. So I suspect was really a torn suture. 3D color is really important in terms of paravalvular leak, sizing and also severity of it. Here you can see there's 2 paravalvular leak really separated by the suture. We measure the 3D vena contractor area, and using advanced imaging such as your true view and your glass view, you can really appreciate the eccentricity of the paravalvular leak regurgitation, and certainly this is a severe paravalvular leak. And certainly studies have shown that 3D color Doppler is superior in terms of assessing, and more so in your moderate or severe paravalvular leak. And also in terms of echo grading of paravalvular leak severity, I think it's like any regurgitation, it's a multi-parametric approach. So you would want to use semi-quantitative and quantitative assessment for your paravalvular leak assessment. So in our patient that I showed you earlier, she certainly has a previous history of endocarditis, which predisposes her to increased risk factors for paravalvular leak. She had multiple surgeries, so her tissues are friable, and other risk factors include calcification, medication use such as steroid use, or procedural factors such as continuous suture in patients who had undergone surgery are risk factors for a paravalvular leak. In terms of the guidelines with the recent publication, of course, patients who are symptomatic heart failure in class 3 or class 4 or who have persistent hemolytic anemia would want them to have paravalvular leak closure, and of course in centers of expertise. In terms of devices, you want to use a large or small nitinol braid such as AVP2 or AVP4 devices, as you can see in this diagram. And of course, the first step in your intraprocedural imaging is your transeptal puncture, which is key. And really depends on where the jet is. If it's a lateral and anterior jet, it's usually accessible from multiple puncture sites. But of course, if it's a posterior or medial jet, it can be really challenging. And also on an anatomy of the interatrial septum, so you would want to really do careful consideration and do other modality imaging to assess that. With the other consideration, the direction to which to cross the defect may be complex during the procedure, and sometimes these defects are difficult to cross. You may want to consider a retrograde access or maybe a transapical access as well. Of course, that would be the last resort to avoid an invasive approach. So in this patient that I shown you earlier, so we perform a paravalvular leak closure and using fusion imaging with Echo Navigator, performing a transeptal approach and crossing the defect with the wire using the fusion imaging of both echo and fluoroscopy. We were able to place the first AVP2, which is a 12 millimeters. And of course, the residual, as you can see on the bottom left-hand side of the placement, that there's at least moderate paravalvular leak residual regurgitation. We proceeded again with putting not only 2 but 3 AVP2 12 millimeters right next to each other using fusion imaging of both the echo and the fluoroscopy. And you can see the final result here that the 3 AVP2 plugs is really well seated. There's no obstruction to the bioprosthetic. The gradient across is 3 millimeters per mercury with a residual mild moderate about 16 millimeters with an absence of flow reversal in your pulmonary veins. So meta-analysis and systemic review have shown that, a successful percutaneous paravalvular leak closure is helps in terms of increased cardiac mortality because these patients do better functionally from NYH class, fewer repeat operations. They do have an improvement in heart failure symptoms, and of course, really reducing that paravalvular leak from severe all the way down to mild or even trace paravalvular leak. So in conclusion, I think advanced cardiac multimodality imaging is key in terms of the success of percutaneous mitral intervention, especially in paravalvular leak closure. Of course, imaging technology is evolving. There's advances in ICE and fusion imaging, as you have seen in the case earlier, and in this case as well, to help improve the communication between us imagers and interventionists and the efficiency of the case. You'll see as well in subsequent speakers with regards to advances in 3D printing, which can help. And with that, thank you very much for this opportunity.
Thanks, Nadira. That was great. Now we're going to go over to Joe Martucci from the MUHC, who is a structural interventionalist with a lot of experience with this, and he's going to give us some of his tips and tricks on from the interventionalist approach.
Can you see my slides? Yeah. Can you hear me well? Thank you for the invitation to present. The key feature in closing paravalvular leaks is really to understand the relationship between the echo imaging, the CT imaging, and the fluoroscopic imaging. The Heart Navigator kind of puts that all together and certainly makes it easier. But there are other ways to do that or to think through the process. So my name is Giuseppe Martucci, and I'm an interventional congenital and structural heart disease cardiologist here at McGill. So the first step to doing a procedure properly is really to have a common language, and so that communication is really important. We go from the surgical view, where the mitral valve is looked at from the atria, to what we call the interventional view, where we're more used to seeing the mitral valve coming from the ventricle and the orientation as represented here. So when we look at the echo imaging, one can appreciate that depending on how you cut the mitral valve, you will either have a 4-chamber view, a 2-chamber view, or a 3-chamber view. It is essential for the interventional cardiologist to become very familiar with the echo imaging. And then the question becomes, how does the echo imaging translate to fluoroscopic views? So the problem we have with fluoroscopy is that we are dealing with a 3-dimensional structure, but the fluoroscopic images are really 2-dimensional. So how do we, make that relationship? So what's key to closing any paravalvular leak, whether it be mitral or aortic, and it was well illustrated in the case that was presented, is that you need to find the appropriate orientation of the valve such that the leak is either on the superior aspect or the inferior aspect of the valve. If your leak is between those two, you have no idea where you are. Okay? So key to any paravalvular leak is finding the appropriate orientation and to identify the leak as either above or below the valve, so that what you've effectively done is you've taken a 3D structure and you've broken it down into a 2-dimensional image. Now, every structure in the body, and specifically in the heart, has what we call an optimal projection curve, or what used to be called, with regards to the aortic valve, the S-curve. So what you can see in this diagram here is you can see the traditional S-curve of the aortic root as it goes from ariocaudal to iliocranial. You can see what is typical of the mitral annulus as it goes from ariocaudal to iliocranial, et cetera, et cetera. So every structure in the heart has a specific curve where if you follow that curve, you will be in the plane of that particular structure. So specifically in this particular case, we are talking about the mitral valve, and this is the S-curve of the mitral valve. And what you can appreciate is that the S-curve of the mitral valve goes from the ariocaudal projection to the ariocranial projection to the iliocranial projection. And in fact, the case that was presented, the closure of the leak was actually done in the ariocranial projection, which is equivalent to a 2-chamber view. Okay, so each quadrant will represent different chamber views, and this is where we begin to correlate the fluoroscopic images with the echo images with the CT images. Okay, and it's extremely important. Now, Echo Navigator does that for you, but you can do that yourself by understanding where those views are coming from. And so if we now take the mitral valve, as we demonstrated earlier, and depending how you cut the valve, you can either get, as we said, a 3-chamber view, a 2-chamber view, or a 4-chamber view. In the case that was illustrated, if I remember correctly, the leak was very close to the left atrial appendage and was best seen in a 2-chamber view, and the procedure actually was done in a 2-chamber view. What was also brought up earlier was that depending where the leak is, your approach to the paravalvular leak can be different. Now, the majority of mitral valve paravalvular leaks are treated through a transeptal puncture, as illustrated. However, you can appreciate on this 4-chamber view of the left ventricle that if your leak is medial near P3, a transeptal puncture would make it almost impossible to actually access that leak. And so in this particular case, an apical view might be more appropriate. Another possibility is through a retroaortic approach. Okay, so before you jump into the transeptal, you have to have an idea of where the leak is relative to the atrial septum. So this is a case that we performed about 3 weeks ago, and oddly enough, the leak is very similar to the case that was presented earlier. And what you're seeing en face is the mitral valve, and as you go to the left lower quadrant, what you are appreciating is a 2-chamber view with the left atrial appendage right here, Okay, and the leak, in fact, is here. You can see contrast going outside the valve, going from the left atrium to the right ventricle, and it's right next to the left atrial appendage. And this green line cuts the mitral valve into a two-chamber view. Okay, the aorta is right here, and then you can appreciate the different structures of the heart. We now take the same picture. We've just reoriented it. So here we go. This is your two-chamber view. Again, identical to the procedure that was, to the case that was presented. Here is your left atrial appendage, left atrium, left ventricle. Here is your valve. You can appreciate that there is contrast going across the left atrium, outside the valve, into the LV. And once you've identified this view as where your leak is, and then the next step is really to do exactly. So this is the procedure. It resembles, whoops, sorry about that. It resembles exactly what was just discussed. And what you see is you can appreciate that the mitral valve is in plane. This is the aortic valve. This patient also had two mechanical valves. The mitral valve is in plane. The leak is in the superior aspect of the mitral valve, as best seen in the two-chamber view, both on echo and on fluoroscopic imaging and on CT imaging. And then once you've identified the leak in the superior aspect, then it's actually quite easy. We cross the valve with a wire. We put a device. In this case, we chose to use the AVP3 device, and we proceeded to close the leak in that fashion. So the key aspect to a paravalvular leak is understanding the relationship between the CT scan, the echo, and the fluoroscopic images, and to maximize it so that the leak can be identified either at the superior or the inferior aspect of the valve in question when the valve is in plane. The different devices that are currently used are listed here. There's certainly one device is certainly not better than the other, but these are the different devices that have been used. And that's all I was going to say, and I'd be happy to answer any questions later on in the presentation.
Thanks, Joe. That was really demystifying. And what really impressed me was that both you and Adira showed the reference the Gary Foster paper from 1998 from ATS, which really is the standard before we had 3D. I still use it routinely. 3D makes it so much easier, though. Next, we're going to switch to Israel Valverde, who's going to give us a primer on 3D printing. Welcome.
Oh, hi. Thank you. Hi, everybody, and thank you for the invitation. So I think the topic I have to cover is just to give you a brief idea of what kind of 3D printed models for several cases. For example, the first one I would like to show you, it's a case of an old lady, 86 years old, with a previous tetralogy of Fallot. We were thinking about replacing the pulmonary valve, doing surgically, but because of the morbidity, surgeons didn't think it was a good idea. The problem we had is it was a large right ventricular outflow tract, something like 36 millimeters. So we had a very fair idea, which is like, why don't we use a dual stent? One stent for landing and another stent for giving support for the pulmonary, for the melody valve. So because we have a landing zone using a Palmas Genesis stent, we could close this stent using a vascular plug. So as you can see, it's a very high risky procedure. It's crazy, but we had no option because no surgery could be planned. So we use a 3D model in order to plan the procedure. And as you can see here, wherever you have planned in advance with the 3D printed models and you give confidence to your interventionalist, it's what you can later reproduce in the patient. So the same wires, the same balloons, the same stents that you have already used in the cath lab for 20 hours playing around with the model, it's what you can reproduce in a couple of hours in your patient. And finally, you can double check that that it was a success. We can double check with intraoperative echocardiography. With my colleagues, Shakil Qureshi and Eric Rosenthal and Marie Nieves Velasco, we had the idea, why not also approaching the partial anomalous pulmonary venous return with sinus venosus ASD using the intervention. One of the points with disease is that we don't have a posterior wall in the SVC. So if we can put a cover stent here, we will create the posterior wall of the SVC, so all the blood flow from the pulmonary veins will go directly into the left atrium. One of the limitations we had is we were not completely sure how much to inflate, if this could compress the pulmonary veins, and that's why we started playing around with 3D printed models. And as you can see here, what we reproduce in the 3D printed model is what we could later do in the patient. Of course, in these initial cases, we kept a wire in the pulmonary veins. With our adult colleagues, we also start playing around about closing left atrial appendage with 3D printed models, several techniques, and that's why we decide to fabricate our own simulator. That may agree with that. I mean, you don't really need to think or plan in advance about the angulation, because you just put the model in the same orientation of the patient, and then you can play with your X-ray until you find the perfect orientation for this particular case. And this same orientation can be later reproduced with your patient. So you just go straightly to 30 degrees or 20 degrees or whatever. And that's one of the workshops we have with our fellows for interventional planning. But we also have used 3D printed model for surgical planning. This is one of the largest studies that we have done, which involved over than 20 centers all around the world, where when a center had a complex case for congenital heart disease, they upload the images to our dedicated server. We did the 3D printing to the hospital, and we evaluated over 40 complex cases of congenital heart disease. What we did is we allowed the surgical meeting to decide what they would think would be the best approach. 1 week later, we send the 3D printed model and recheck if they agree in the same surgical intervention. And what we found is that the 3D printed model changed in 44% of the cases the surgical plan of complex congenital heart disease. And in 15% of them, they changed conservative or univentricular heart physiology palliation for biventricular repair. But maybe I think that one of the future leads will be the imaging fusion. But doing the imaging fusion, what will be the key, because here we will understand much better the paravalvular leak, the valves, the subchordal attachment, and that's something we can do right now using hybrid imaging fusion combining MRI, CT, and 3D echo. And thank you very much. I hope I was brief enough.
Thanks, Israel. That was fantastic. When Joe talks about the S-curve, it takes people to come up with the concepts of S-curve and to model. So now we're going to hear from Pascal Thériault-Lauzier, who's a cardiology trainee at the Ottawa Heart Institute, who has a lot of experience in developing these models and actually gone on to commercialize these models. So he really is an expert in the field, and he's going to give us a little primer on how we create modeling software and what it takes.
Can you hear me well? Thank you, Dr. Rutsky. It's a pleasure to be presenting today. So I wanted to touch base a bit more on the technical aspects involved in 3D printing and modeling anatomy and how this is done on the software. And so I have no disclosure for this presentation. So what I'd like to go through is the process that takes us from a CT scan all the way to a 3D printed model. And this is not a necessarily a trivial process. So the first step in this process is to perform a threshold-based segmentation. So this allows us to extract the anatomy, smooth out the segmentation, then we treat a 3D mesh of that anatomy, and then we send it to the printer. So I like to think of a CT scan as a matrix of voxels, and we can see they're in 3 dimensions. And within that matrix of voxel, we have a region of interest, a volume of interest that we want to extract. So one way to do this is using the ounce field units that are present in the patient. So this is a CT scan slice with a patient who's received IV contrast agent. And what I've done here is trace the line through the left ventricle. And we can follow along the line here, and we've plotted the attenuation versus the position along this line. And we see if we're in the myocardium, we have a low attenuation, and we reach inside the ventricle, the attenuation increases, then decreases again once we reach the other side. So what we need to define is the position of these points. Where is the ventricle starting and ending? So what is done in the vast majority of software is using a threshold. So you move the threshold up and down in order to decide where this limit is going to be. Now you can already see how this can lead to errors. So for example, if you select a threshold that is too low, you may end up overestimating your region of interest. So that is definitely something to be very careful with. And if you move too high with your threshold, then you will undersize your region of interest. So this is definitely a very crucial point, especially if you're trying to use a technique like this to plan a procedure. And in such a case, you would want very accurate measurements. So this needs to be done, of course, by an expert in order to get very accurate measurements. Now, once you've selected your threshold, the next step is to perform the segmentation step. And the segmentation step essentially produces a mask. So an image with zeros for pixels that are outside the mask and ones for pixels that are inside the mask. So once you have that, you can apply some post-processing to smooth out the small irregularities of the model and create something that's much easier to process. Next, you don't want to know exactly each pixel. You want to know exactly the position of the surface surrounding that region. So this is done using a 3D mesh, and you have to select the resolution of the mesh in such a way that you properly model the anatomy that you're interested in. So the creation of this mesh is done automatically by the software, but you do have control over how finely the mesh is developed. This is an example of a heart model that we created a few years ago, and this is really this mesh that I was discussing about earlier. Once you've created this mesh within your modeling software, what you can do is save it as a file, and then you can send it to a 3D printing facility to be printed. In the vast majority of cases, this type of printing would be done slice by slice, going inferiorly up to the top of the model. And you have to be careful. There's some subtleties in how this is done, and you have to understand some of them when you're creating that model. For example, if we had the IVC here that was protruding a bit lower, and the model starts printing here on the table of the printer, and then it reaches a point that's higher up in the model, you could actually create a torque on the model, and this would create a completely disastrous result for your 3D print. So in order to avoid that, you often have to add 3D support structures to your model in order to allow this 3D orientation of your model. So this can be non-trivial to do. So you need to have, of course, expert hands to do these kinds of modeling. This is the example that we have. Once we've printed it, we can see the opening of the mitral valve and tricuspid valve in this case. Now, of course, if you're interested in trying this out on your own, there's some tools that are available for free online. So there's 3D Slicer that you can download and try to segment the heart and create this 3D mesh that was discussing before. And you could, in theory, send it to a printing company for this to be done. There are now some companies that specialize in this. Materialize is one of them, and they take care of the whole process from A to Z. Interestingly, we speak of testing how an implant would fit within a given anatomy, and the intermediate step is the 3D printed model that we generate in order to test that. Interestingly, over the last few years, there's been some development in virtual implants. So interestingly, creating an anatomy completely virtually, and then placing a device and see how it deforms within that anatomy. And what this allows to do is to model the flow of blood around the device and see how well it would seal, for example, in the cases of a TAVR device. So this may be a direction that the field would go in the future. So this is the discussion I had. Here's some of my references. So thank you very much.
Thanks, Pascal. That was great. I'm still waiting for the audience to send questions, but in the meantime, we'll go through some questions addressed to the panelists. First question is to Dr. Alcantara. You had a single paravalvular leak, but often we have more than one paravalvular leak around the prosthetic valve that we identify. How do we best assess the sizes, the locations, and how do we decide which ones we're going to close, which ones we're going to leave behind, or we just go ahead and close everything that we can?
Thank you, Lawrence. I believe that's why echo evaluation is so important. It's very important to have a very thorough echo evaluation to quantify the severity of each PVL. And Nadira has just stressed the importance of this. 3D echo and 3D echo tools are specifically important for this purpose. And if the echo guys determine that you have two severe leaks, well, then you should pay much attention and treat them appropriately. And I believe this also stresses the point and the importance of working as a team. So I believe echo is the key to the evaluation of the severity of PVL.
In relation with this, I have a question for Nadira. Thinking on sizing of the paravalvular leak, which would you prefer? We have echo or cardiac CT, and also, of course, 3D echo, I think. But between 3D echo and cardiac CT, what do you prefer for sizing? Do you think that there are different, better cases?
Thank you so much, Dr. Vidal-Perez, for the question. And I think, like what Dr. Alcantara mentioned, that I think really precise imaging, really to characterize the PVL. And I think first line, as you mentioned, echocardiography is the first line. Thorough investigation, meticulous interrogation is really key. But both 3D TEEs and CT actually can allow for visualization of the size, the shape of the paravalvular leak, and also the spatial relationship to the surrounding structures. So your transeptal puncture, as mentioned by the other speakers, I think it's all very key to multimodality imaging. If you obviously with 3D TE, I think the good thing you can quantify it, like you mentioned, the severity of it by Doppler techniques. The key with the 3D TE is really using color as well, because if you use without color, you can get the dropout artifacts. So sometimes you can overestimate that sizing of that paravalvular leak defect. So really meticulous interrogation using 3D color Doppler, and also CT can be used for sizing of this paravalvular leak.
Thank you.
Thanks, Nadira. I think the echo is better for quantifying the amount of flow, and the CT often for the anatomy, but the 3D echo really is great in terms of localization. One of the little tips that we have sometimes is when you're using 3D color, there's a whole lot of color and it's coming from everywhere. So I like turning down my color gain, my color Doppler gain, all the way down to see where the jet origin is if there's just way too much color everywhere. Now switching over to Joe again, we've talked, the whole case was about mitral paravalvular leaks. You guys have to deal sometimes with aortic paravalvular leaks and TAVI paravalvular leaks. What's the approach there in terms of localizing, assessing the severity, and your technique for closure?
Yeah, thank you for that question, Lawrence. When it comes to, whether it be aortic or mitral, the concepts are always the same. really what you need to do is find the valve in plane and find the leak so that it is either above or below. I'm going to repeat that because that is the key to the interventional procedure. And so, of course, the anatomy, the surrounding structures are different. The mitrals tend to be a little bit more challenging because you're in the left atrium, and the left atrium is of course a three-dimensional structure, and you have pulmonary veins and left atrial appendage, etc. When you're dealing with an aortic paravalvular leak, you're in the chamber of the ascending aorta, which tends to really mirror, if you will, the aortic valve. So it's much easier to find the leak from the aortic. But the challenges are pretty much the same. And the key, again, is to isolate the valve in the appropriate orientation to find the leak so that it's really, so that you can reconstruct a 3D structure into really a 2D structure. With regards to TAVI, again, the concept is the same. The only challenges with the TAVI, and most of the significant paravalvular leaks that we see are with self-expanding stents, so the core valve, for example. The challenges there are that you need to go through the stent struts first before actually reaching the annulus. So that adds a little bit more challenge in terms of navigating your catheter through. But the concepts, again, are we use exactly the same approach, whether it be aortic, mitral, or if it's a transcatheter valve.
Thanks. I imagine, though, there's a little bit less real estate when you're dealing with the aortic valve, using smaller plugs and less space to put it in.
You know, the sizes, I think you're probably correct. There's some issues that we didn't discuss earlier. When we talk about complications of paravalvular leaks, you know, we talk about heart failure as one of the main indications, but sometimes we convert someone with heart failure into someone with hemolysis. So, you know, often, unfortunately, these paravalvular leak closures are not perfect. We generally don't close them at 100%. And sometimes we convert a large leak into a very, very small leak with high velocity, and specifically in the mitral position where you're going from an LV systolic pressure of, let's say, 120 to an LA pressure of 20, that gradient can result in hemolysis of the red blood cells, whereas in the aortic position, that tends to be less likely. But the sizes mitral tend to be a bit larger than the aortic sizes, absolutely.
Thank you, Joe. I have a question also for Israel. He showed us this 3D printed model for this interventional and surgical planning of complex cases. Now the point is how accurate are these models? It's like the native tissue. How you mimic the compliance of this pulmonary artery when you simulate with the two stents using conventional materials, or maybe you need special materials to get something more realistic?
Thank you, Rafael, for the question. Can I share some slides? It's in the task, particularly in the interventionalist meetings. So we did a study and we compared 120 anatomical structures, which I can show you here. 320 anatomical structures in children and small kids and also in adults, comparing what's the size of the SBC in CT, MRI, and compared to the 3D printed model. And what we found is that the accuracy of the 3D printed model is just below a millimeter of difference, which is more than enough for planning surgery or interventions. And the other thing that they usually ask is about the compliance. And it's funny because when you do a pulmonary valve or aortic valve dilatation, you have no clue about the compliance of the patient. You just use a regular balloon. And that's what we did with the 3D printed model. You should open a pulmonary valve using the nominal pressure of the balloon and should not burst. That's what we started doing. We play around with different materials to open and close pulmonary arteries, aortic valves, and according to the thickness, we found that, for example, if you are using polyurethane, you could open a pulmonary artery using the same nominal pressure, but you have to use a wall of 0.4 millimeter. And if you want to open an aortic valve, you need to use a different material. So you use tango material, but not polyurethane. So I think we can fairly predict the same mimicking condition of the tissue. The only thing you have to play around is with the thickness of your material.
Thank you.
Pascal, We've heard you've spoken and other speakers talked a little bit about the evolution of simulation. So do you think the future will see more virtual implants or more 3D printing, and what are the strengths of each approach in your mind?
Yeah, that's a great question. The main limiting factors, I think, with 3D printing and virtual implants is the time requirements to be able to do that, and the expertise required to do a 3D model like this. So definitely there are many different steps and involved. The main issue I would say would be if an interventionalist has a likes to see what they're going to be intervening upon, and likes to really look at how the device will fit inside of it. That can definitely be a strength for a printed model. Well, a virtual model would be something that that can be produced and can be visualized on a computer screen, but doesn't give you the same tactile feedback. But it may be much more efficient to produce. So you may be able to get a virtual implant done relatively quickly and cheaply. So this may have a role in the future, and these techniques are used in very special cases, and if we're going to be using 3D printing at scales, it would require very specialized training. So definitely we'd have to to have virtual techniques in addition in more simple cases probably would be very appropriate.
Thank you. I want to ask a question to the panel, and you can free answer any of you, maybe depending on the topic, because these are two parts. What do you think about the follow-up after the procedure? What is the recommended thing to do about imaging? When to repeat, what to repeat, and then also is related with prophylaxis. Do you think these patients need endocarditis prophylaxis? In which kind? So I think first, probably Nadira first to one is how is the follow-up with imaging?
Thank you very much, Dr. Vidal-Perez. I think in regards to echo imaging follow-up, obviously before the patient's discharge, I think just to make sure, seeing the residual regurgitation, looking for gradients, looking for any other complications post-procedure. And I think follow-up would, what we do routinely in our practice is really the 30-day follow-up. We see them to see whether there's symptomatic improvement from whatever indication that they had for their percutaneous paravalvular leak closure. And then thereafter, a couple of months, stagger it 3 or 6 months, and then hopefully yearly, depending on their outcomes during their clinic visits.
Thank you. I'm open to the interventionist Marco or Joe about the pharmacotherapy. Do you need some additional antiplatelet for a long time, prophylaxis?
Thank you for that question. The majority of when the patient has a mechanical valve, then it's obvious they go on anticoagulation, so that's easy. When they have a biological valve, our general approach, without any good data, is that they go on at least a single antiplatelet therapy. With regards to endocarditis prophylaxis, I think as long as there's a residual leak, we tend to give antibiotic prophylaxis. But again, there is no data to support that. It's just our practice here, our local practice. But I'd certainly be interested to hear what other practices are across the world.
Yeah, we do much the same as Joe. Most of the patients that have mechanical valves, it's easy. They are on warfarin most of the time. But the ones that are on bioprosthetic devices, we go only with single antiplatelet therapy. And as Joe already told, if he has a high velocity jet, that's a high risk patient for developing endocarditis. So that patient, we try to teach him that if he would go to any invasive procedure, he should tell us so we can give antibiotic prophylaxis. But I believe we perform much the same practice.
I'm just going to jump in because we have a question from the audience related to 3D printing. How are different hospitals managing the labor and cost for 3D printing models, cost of materials, the cost of technician to segment CT, cost of the printer and printing filaments and post-processing. In the U.S., it's not reimbursed by insurance to my knowledge. So we don't have, I don't think we have people who do that on the call in the U.S., but if anybody has any idea on how this works.
You know, Lawrence, I would just say, I have no idea how it works, but I would just say that, of course, 3D printing, we do use 3D printing. We use it in our congenital, our complex congenital procedures. So sinus venosus, ASD closures, which we're going to do one next week. We did a 3D model, and some of the pulmonary valves. But I want to just emphasize that if you really understand the relationship between what you see fluoroscopically, what the CT scan tells you, and what the echo images tell you, and if you could really integrate in your head those three images or imaging modalities, I think you can go a long way without necessarily always needing 3D. I think 3D printing and modeling is exceptional. I think it's fantastic. We've done it a few times. But I think once you start to understand the relationship, you can use it in very selected cases. It'd be interesting to see what other people think. If this is the routine of their centers, etc.
So I think Israel has probably the most experience, but you know, you speak like a seasoned veteran, a master clinician, as many people on this call are, and we're always the people who you know, the new technologies we see as the great equalizer, right? It just does really, once you start using them, it does make it all that much easier. Like I would still go through the Foster mapping, and I still do, but I can put my 3D button on and I can see the same detail, and I have to figure out in my brain what's dropout and what isn't, but instantly. So it could make it so much easier to use the new technologies. At some point, the new technologies will become the old technologies. But I appreciate, as an old school echocardiographer, I certainly appreciate what you're saying. But let's hear if we have any other comments.
Carlo Israel, you want to add some point about the value of 3D, additional
Yeah,
value?
I think the value of 3D print is just not for senior interventionalists or senior imagers who after several years or decades, they were able to put their brain in 3D. It's also for the new generation. It's also for training people, for training. I mean, it's nice that you work in a huge center doing 300 PAPVDs or whatever, but some of the centers, they don't see so many cases. So for them, it's nice to have like a 3D printed library where we can share cases and they can download the cases, print the cases, and they play around with young fellows, but also for starting doing new procedures where they don't have so much experience. So I think that's the advantage. And of course, I think my experience with the big people like JACC Qureshi, I mean, they are kind of enthusiastic. They play around with the 3D printed model, and after they know the routine and the technique, they don't need the 3D printed model anymore. Fair enough. But our new fellows, they need it every single year because they are new fellows. So I think that's the advantage of this new technology. It's not replacing, it's making things very easy.
We're going to close this session. This was a great discussion, great case. On behalf of the ACC Imaging Leadership Council and JACC Case Reports, I want to thank all the panelists, the presenters, the audience. As the authors state in their case report, percutaneous procedures are becoming more and more prevalent, and I urge you to read the case in JACC Case Reports. The key really to all structural procedures, as was said over and over again, is the concept of planning and understanding the anatomy. 3D printing can help us to better visualize and try out different closure devices. Advances in 3D modeling software and augmented and extended reality may help us simplify that process, as we heard, in a more timely and cost-effective manner. It's really an exciting area that highlights the symphonic collaboration between the interventionalists, the imager, the clinicians, the computer programmers, and the engineers even. Just to remind everybody, this session was recorded and it should be available by next week on the Imaging Council website. And thank you very much, everybody, and have a great day, evening, wherever you are, and stay safe. Bye-bye.
Bye.
Thank you. Bye-bye.